section is on sleep disorders for behavioral science and psychiatry for Falcon Physician Reviews. So normal sleep is divided into two different phases. You have your REM sleep and your non-REM sleep. And what does REM mean? It means rapid eye movements. So if they ask you a question about that, instead of saying REM, they say rapid eye movements. It's the exact same thing. So in non-REM, you have stages of 0 to 4, and then REM does not have any stages. So when you're awake, there are two different types of waves that are found on the EEG. You have your beta waves, which show active mental concentration, and then you have your alpha waves that show relaxation with your eyes closed. And they can ask you this question on your USMLE. They might give you a vignette of a person that's just relaxing in a chair and asking you what the predominant sleep wave will be. Now, in your non-REM, which is your stages 1 through 4, these are very high yield points. And what they'll do is they will give you the vignette of a person who's sleeping, and they'll say, well, you will see these kinds of waves, what stage are they in? Or they will give you someone who has a parasomnia and ask you what stage it occurs in. So stages of sleep will be very important for you. So stage 1 is the lightest stage of sleep. Generally, you will see theta waves, and you'll have a slowed pulse, respiration, your blood pressure will go down, and this only constitutes about 5% of your sleep time. Not a very important stage of sleep out of the 4. But stage 2, actually, you spend about 45% of your sleeping time in stage 2. So this is where you spend a majority of your time sleeping. And the most important points about stage 2 is that you will see sleep spindles and K complexes. I would remember that for your exam, because that will help you identify that they're talking about stage 2 sleep. Next, you can actually group stage 3 and 4 together. Now, this is considered deep sleep. And in deep sleep, you have delta waves. So both of those are D's, deep and delta. And this is slow wave sleep. It's very deep. You're very relaxed. And this is frequently where a majority of your parasomnias occur, such as night terrors, somnambulism, which is sleepwalking, and enuresis. And stage 3 and 4 constitute about 25% of your sleep time. Now, stage 4 is where the human chorionic gonadotropin, or the HCG, is also released. In non-REM sleep, your mind is asleep, but your body is awake. Also, your autonomic functions are decreased, and your growth hormone is also secreted in your non-REM sleep. So how will you remember your non-REM sleep? Your body is moving, but your mind is asleep. Now, REM sleep will be the exact opposite. Your mind is awake, but your body is paralyzed. And you will also have an increase in your autonomic function. So your pulse will be increased, your respirations will be increased, and your blood pressure will also be increased. You'll be dreaming during this time. So frequently, when people come and wake you up, or your alarm clock comes and wakes you up, you'll notice that you're dreaming and you're coming out of a dream. Well, that's because you're in REM sleep. And as you sleep, your REM periods increase progressively throughout the night. So towards the end of your sleep, you actually have more REM sleep. Now, it takes about 90 minutes to get into your first REM episode, which means that from the time you've fallen asleep to the time you've gotten to REM, it's about a 90-minute time, and that's called REM latency, and that's normal. And later on, we'll discuss times where you'll have a decreased REM latency or an increased REM latency. Also, I did mention that your brain is awake and your body is paralyzed. But in REM sleep, you will notice the penile and clitoral erections. And you know how they say men have two brains? Well, so if you can remember it that way, then you can remember that your mind is awake. That's when you have your erections, because those are the two brains of the men, and your body is asleep. Characteristically, they have very sawtooth beta, alpha, and theta waves, and these are very, very small frequent waves. And this constitutes about 25% of your sleep time. So what is sleep latency? Sleep latency is the time that it takes for you when your head hits the pillow to when you fall asleep. So from when your head hits the pillow to when you enter your first stage of non-REM sleep. Generally, this should take less than 30 minutes for people to fall asleep. And for most people, it takes about 10 to 15 minutes. Now, your REM latency is the time from when you fall asleep to when you enter into your first REM period. Generally, it takes about 90 minutes, can take up to 120 minutes. And these non-REM REM cycles repeat themselves repeatedly every 90 minutes or so. and you have about 4 or 5 REM cycles per night, and they become more longer and frequent as the night progresses. So what are the different neurotransmitters of sleep? Both serotonin and acetylcholine promote sleep, whereas norepinephrine and dopamine promote wakefulness. Now, serotonin, that makes sense. So people who are depressed frequently have a hard time falling asleep. So when you give them a serotonin reuptake inhibitor, which increases their serotonin in their synaptic cleft, their sleep is one of the first things that improve. So that makes a lot of sense. As well as acetylcholine. When people get older or when they have Alzheimer's dementia, they have less acetylcholine, they don't sleep very well. I don't know if you've noticed your grandmother and grandfather, they don't sleep as long. They see you, they fall asleep, and then they wake up really early. They don't need as much sleep as we do. Well, that explains why acetylcholine decreases sleep if you don't have enough. And norepinephrine and dopamine are kind of stimulant kind of neurotransmitters, so it explains why they would promote wakefulness. So where do you get increased sleep latency? So that means where there's increased time for you to fall asleep. Adolescence is one. Poor sleep hygiene, for example, if you've taken a nap in the afternoon or you just drank a Coke before you went to sleep. Depression, anxiety, mania, these are all reasons why it's hard for people to fall asleep. Now, where do you get a shortened sleep latency? Adulthood and elderly. Elderly usually fall asleep pretty quickly. You know, they're talking to you and they're out, but they don't sleep as long as we do. Alcohol and drug-induced sleep, narcolepsy, sleep apnea, and sleep deprivation. So there's different types of sleep disorders. You have dysomnias, which are problems in timing, quality, and the amount of sleep. And then you have parasomnias, which are abnormalities in the physiology or behavior associated with sleep. So the different kinds of dysomnias we're going to talk about are narcolepsy, sleep apnea, insomnia, hypersomnia, and circadian rhythm sleep disorder. And parasomnias include sleepwalking, sleep terror, and nightmare disorders. So what is narcolepsy? This is excessive daytime sleepiness with changes in your REM period. So what these patients will do is that they'll be in class or at work, and all of a sudden they'll just fall asleep and they will immediately enter into the REM period, which is actually not normal because from what we learned before, you generally go through a stage of non-REM and then you go into a REM stage. So what these patients do is that they immediately go into a REM phase. Now, the clinical presentation of a patient with narcolepsy is cataplexy, and what cataplexy means is that suddenly these patients will get a heightened sense of emotion, such as they'll laugh, they'll cry, all of a sudden they'll lose all muscle control and they'll fall to the floor. And then eventually they'll get back up. Another symptom is sleep attacks, where these patients will suddenly just fall asleep. They can fall asleep when they're driving, when they're in a lecture. Sleep paralysis. This is when patients will be awake, their mind will be awake, but they feel like they can't move their body. And hypnagogic and hypnopompic hallucinations. Now, these are the only types of normal hallucinations. And what hypnagogic hallucinations are when you're going to sleep. And how are you going to remember that? Hypnagogic has a G, and when you're going has a G to sleep. Well, that's a way to remember hypnagogic. And hypnopompic is when you're waking up from sleep. So how will you treat someone who has narcolepsy? Want to establish a very strict sleeping schedule with frequent scheduled naps if possible. And also you can use some medications. Now, tricyclics such as imipramine can be helpful with the cataplexy, and also psychostimulants and modafinil are helpful with narcolepsy in general. Next we have sleep apnea. And how they tell you sleep apnea on the exam, it's going to be very easy for you to identify. It's generally going to be an overweight, obese man who comes in with his wife, and his wife is just complaining. My husband doesn't let me sleep, he's up all night snoring, I've had to move out of the bedroom, please doc, do something about this. Okay, so that's what your vignette's going to look like on your exam. But what is sleep apnea? It's a periodic episode of apnea during sleep. And it can be either due to a central reason, such as in your brain, or it can be due to a peripheral reason, such as obesity, maybe you have an adenoid problem, a tonsil problem. Now, this doesn't just occur in an older man. It can occur in children, it can occur in women, but commonly does present in an older, obese man. Patients frequently awake unrefreshed, they're sleepy a lot during the day, they have high blood pressure, dry mouth, and depression. Now this can be pretty severe on your body. They can experience blood oxygen desaturation, cardiac arrhythmias, pulmonary and systemic hypertension, morning headaches, confusion, depression. So this is a pretty severe illness that's easily treated and should be recognized and treated immediately. So you have obstructive sleep apnea, where there is an upper airway obstruction due to some kind of thickened tissue such as tonsils, adenoids, that kind of a problem. Then you have a central sleep apnea where you don't have a good CNS respiratory effort. It's very inconsistent. Again, you will remember to look for an old man. His wife comes in, she's complaining, and usually he's not complaining as much as his wife is. And how will you diagnose sleep apnea? Well, you'll do a sleep study or a polysomnogram, and you'll notice that they will have 30 or more apneic episodes, and that's usually diagnostic. So what are the consequences of sleep apnea? You'll have insomnia, daytime somnolence, impaired intellectual functioning, impaired concentration, and depression. How do you treat it? Treatment of choice is CPAP. So on your exam, if you see sleep apnea and they'll have CPAP, they'll have lose weight, most likely your patients are not going to have a difficult time losing weight. They're not that motivated to lose weight. But CPAP will be your treatment of choice. Again, weight loss is helpful. Sometimes surgery can be helpful. And frequently when they first use a CPAP machine, they will definitely sleep much better. Other treatments for sleep apnea is that you can do some behavioral treatments. Make sure they're not taking a sedative hypnotic, which can pull them into a deeper sleep, and if they have an inconsistent respiratory drive, that can be a big problem. Again, frequently it's better to sleep on your sides because when they sleep on their backs, the snoring becomes worse. You could also use some mechanical devices such as orthodontic appliances or tongue-retaining devices. And surgical options include uvulopalatal-pharyngoplasty and laser palatoplasty. Sedatives can make sleep apnea worse, and they can worsen COPD, which might be a cause of sleep apnea, and it can push the snorer actually into sleep apnea. So you want to avoid a sedative hypnotic as much as you can in a patient with sleep apnea. Next, we have something called insomnia, or primary insomnia, and this is where patients have a very difficult time falling asleep and staying asleep. And what happens is because they don't sleep all through the night, they have an increased amount of daytime sleepiness. And often it is due to the fact that they don't have very good sleep techniques, so they have poor sleep hygiene. But you also want to rule out, is there a depression, an anxiety, some other kind of mental illness that may be causing them to have some insomnia. Now, for your exam, the most common cause of insomnia is poor sleep hygiene. But the most common pathological cause of insomnia is depression, and the most common cause of excessive sleep is sleep apnea. So for someone with insomnia, be sure to evaluate for any alcohol, any diet changes, medications, any other drugs, sleep disorders, any CNS lesions. Rule out any general medical conditions. Sometimes people have significant pain which prevents them from falling asleep. So if pain is what's causing them a problem with sleep, well, you'd want to give them some pain medication so that they could treat that problem. Also be careful that certain medications and certain substances will affect sleep. Look for any mental disorders, look for any sleep apnea or breathing related problems, and look for any parasomnias. So how do you treat insomnia? Well, the first thing you want to reiterate to your patients is good sleep hygiene. And what is good sleep hygiene? Basically what good sleep hygiene is that your bed is only for use to have sleep and to have sex in. That's it. You don't eat in bed, you don't read in bed, you don't talk in bed. Because what happens is that every time you get into bed, your body doesn't know that it's time to sleep. It thinks that maybe it's time to read, maybe it's time to eat. So all those activities need to be done outside of the bed. You only sleep in bed. And say you've been in bed for about 20 minutes and you can't fall asleep, well then you get out of bed and you go somewhere else, take care of some business, and come back to bed when you're feeling sleepy. No long daytime naps. Try to only sleep for about half an hour during the day, and try not to make sure that it's not too close to your bedtime. And also, don't drink a cup of coffee after 5 p.m. or don't drink a cup of coffee or tea at dinner time because that can affect your sleep. Avoid large amounts of alcohol in the evening. And don't work in bed, no TV, and don't have a large meal before you go to bed. Now, a cup of milk, a little sandwich, that's not bad, but a large meal is very difficult for people to fall asleep after. Also, what you can do is do some sleep deprivation techniques to help insomnia management. You can do sleep restriction therapy. You can help them with relaxation techniques. Medications that you can use are sedative hypnotics, such as benzodiazepines and non-benzodiazepine-like medications, but try to only use them for 30 days or so and use them only as needed because these are medications of abuse. Pharmacological interventions for insomnia, we have medications such as zolpidem and Zaleplon, and these two medications are non-benzodiazepine medications. You probably better know them as Sonata or Ambien. And these medications work similar to benzodiazepines, but they are not benzodiazepines. And we think that they carry less risk of addiction and abuse. But again, people can get addicted to these medications, so it is better to use them for short-term periods. You can use benzodiazepines, generally the longer-acting ones like Klonopin. Temazepam is a good medication as well because you don't have to worry about any withdrawal if the patient stops them abruptly. Trazodone, which is an antidepressant, we don't use it at antidepressant doses, but frequently use it at lower doses to help people sleep. Again, remember what the USMLE side effect for trazodone is priapism. And antihistamines. First of all, you can just start off by giving them some Benadryl. Ask them to take about 25 milligrams of Benadryl, and sometimes that will be very helpful. Next, we're going to talk about the parasomnias. So first we have nightmare disorder. Now, nightmare disorder is going to occur in your REM sleep, and this is very common. And how are you going to remember that nightmare disorders occur in your REM sleep? Well, most people remember their nightmares. So when you remember, the first part of remember has the word REM in it, so that's how you're going to remember that nightmares are in REM sleep. So any dreams that you remember as well, that's all in REM sleep. And with nightmare disorder, the person awakens due to the dream, and they always remember. And the treatment of this is reassurance. Again, if the nightmares are not around some kind of trauma, then you can just do some reassurance and tell the patient everything's okay. But if they're having some kind of post-traumatic stress disorder or some severe anxiety about something, these can be treated pharmacologically as well. Next, you have sleep terror disorder. And what they'll try to do is confuse you between nightmare disorder and sleep terror disorder on your exam. But the difference is that in sleep terror disorder is that the patient wakes up because of some scary dream or anxiety, and these will generally be young males, a young child, maybe 8 or 10-year-old, and then he'll wake up and he'll be screaming, but he won't remember anything about the dream. He'll just wake up afraid, and he'll also be noted to have an increased autonomic response. So that's how you're going to differentiate between a nightmare and a night terror. And night terror, it occurs in non-REM sleep in your stages of 3 and 4, and you don't remember. And then you have somnambulism. Now this basically means sleepwalking. Again, usually starts in stages 3 and 4. Patients will sometimes wake up, they'll eat something, watch TV, sometimes they'll even walk outside of the house. So if you have someone who's engaging in some dangerous behaviors like going outside and leaving and walking in the middle of the road, you want to make sure that all your doors are locked and there's an extra lock. Generally, people who have sleepwalking don't go out and kill people. So if someone comes to court and says, oh, I have sleepwalking disorder and I accidentally kill someone in my sleep, they're probably malingering, so something we need to watch out for. But people with somnambulism also usually don't remember what had happened that night. They don't remember walking in their sleep. Another one is sleep talking. This is also very common, occurs in your non-REM sleep, and it usually occurs in younger children, and it might be associated with night terrors and sleepwalking. Again, there's no treatment needed, just reassurance, and they will not remember. So what are other sleep disorders? This is more high-yield points for you for your sleep disorders, because they will ask you, what are the effects of alcohol in sleep? And what are the effects of benzodiazepines, barbiturates in sleep, and also what is the effect of depression on sleep. So if you are intoxicated with alcohol, you will have a shortened sleep latency, your sleep will be disrupted, and your REM period would also be fragmented, and you'll have actually decrease in your REM period. You'll have more slow wave sleep, so there'll be more delta sleep. And what happens is that on withdrawal, you'll actually notice to have REM rebound, which means the REM that you did not have during your intoxication phase, it will come back to you and be increased during your withdrawal phase. So people frequently notice that when they're coming off of their alcohol, that they will have more dreams or nightmares. Benzodiazepines and barbiturates are also very similar. Both of them will have a decrease in REM sleep. You'll also have some rebound when you stop the medication. Depression in sleep. In depression, you will actually notice an increased REM period in the very early part of sleep rather than in the later part of sleep. Also, you'll notice that it takes much longer to get into REM, so their REM latency will be increased. You'll notice a decrease in your slow wave or your stage 4 of sleep, and these patients will frequently have early morning awakening. Next, we're going to talk a little bit about restless leg syndrome. And what this is this occurs right before you're falling asleep, so patients can still be awake, and in the early parts of non-REM sleep. And it's a very unpleasant sensation where it's in your calf muscles and you feel like you have to constantly move your legs. Generally, it gets worse when you're sitting and resting in bed, and it delays and interrupts sleep. Treatment for restless leg syndrome is to give a dopamine agonist. Bruxism and enuresis are the last two sleep disorders we'll be talking about. Bruxism is the forceful teeth grinding or clenching, and this can be associated with mental retardation, Parkinson's, dementia. It can also be associated with increased anxiety and stress. Usually occurs in younger children, and the problem with it is that it can lead to headaches, temporomandibular joint problems. And what the treatment of this is, usually people will wear braces and mouth guards to prevent them from doing this. This primarily occurs in stage 2 sleep, and that's important for you to know as well. Enuresis or bedwetting, this is more frequent in boys, younger boys, usually occurs in the early part of your sleep, but it's not really restricted to any kind of sleep stage. And again, to diagnose a patient with enuresis, they must be older than the age of 5. And they also must have been completely potty trained and then have slipped back to have enuresis. Also, if it happens in an adult, consider a dementia, consider a seizure, and also you want to consider any kind of drug problems where they're so intoxicated that they didn't get up and go to the bathroom. Is there any diabetic problem or nerve problem that they couldn't feel the sensation? This concludes our discussion on sleep disorders for behavioral science and psychiatry for Falcon Physician.